I'm David Carbone. I'm a thoracic medical oncologist at Ohio State University in Columbus, Ohio. And I wanted to start out by saying how incredible it is to be here today with a room full of people and all the people online, all focused on lung cancer and specifically ALK positive lung cancer. The energy is incredible. The science we've heard about is incredible. And my mission in the next few minutes is to really emphasize how the science has brought us tremendous way forward in treating this disease and improve the quality of life of many people in this room, and that it will be science and further advances in science, and some of which we've heard about today, that really will make the next big leap in improving treatment of this disease. But I also understand that this is not a theoretical argument for people in this room. This is a very personal argument, and the science takes time, and it's the people in this room want the science to be, make a difference now and need that difference now. And so we really, I think meetings like this really emphasize the urgency of making progress in this disease. So we all know that lung cancer is still the number one cause of cancer death in the US, and for both men and women. And most lay people don't understand that still. They think, oh, it's breast cancer for women. But lung cancer in general is still the number one cause of death. And when I started in lung cancer 35 years ago, it really was unclear whether any treatment improved outcomes at all. And it was felt to be ethical to do randomized trials with no treatment in one arm. Just people had no treatment versus random chemotherapy. And you can see this is a trial from 1995 that showed that chemotherapy improved survival from about 4 to 6 months in non-small cell lung cancer. And this was just months of survival. And then we thought we were really smart, and we developed a bunch of chemotherapies, and everybody had their favorite chemotherapy. And this ECOG trial compared them all together, and you can see that really there's no difference between all those chemotherapies. The average, or as Ross said, median survival was a whopping 8 months. And the people alive at out to 3 years, the really anecdotal number of survivors of metastatic lung cancer at 3 years. And you have to understand that these are patients that are excellent performance status. They were treated by the best doctors at the best centers, and really still at that time, now in the early 2000s, the average survival for lung cancer was still at less than 6 months. But we've seen a dramatic improvement in the last few decades. Lung cancer death rate, deaths per 100,000, it's that top line, have decreased by 56% in men since 1990, and 32% since in women. And 5-year survival after diagnosis for all comers with lung cancer is almost doubled, from in the 10% range to over 20%. Okay, so a big part of this progress in improving survival in lung cancer is through targeted therapies. And that's what we're talking about at this meeting today. And it's now in the guidelines that all patients should have a genetic analysis of their tumors before they get started with treatment. And it's really unfortunate. In some data I've seen recently, only about 70% of patients get tested at all. And only about 40% have actually therapies started before the results are back. This in all the community hospitals across the country. And I think this is tragic. If you miss one ALK fusion positive patient, it's a tragedy. And I think we really need to, like Christine Lovely mentioned this yesterday, part of it is science and part of it is implementation, getting it to people. These are the different fusion partners, the drivers that are in the NCCN, but we're talking today about ALK. and there's ALK fusions. We've heard about them. They get rearrangements, they turn on cancer to grow. And this is not a subtle thing. This is a patient I saw in 2011. So a young never smoker. They thought she had pneumonia, treated her with antibiotics. She got more and more short of breath, found out she had not pneumonia, but lung cancer. And then she got so desperately short of breath, she ended up on a ventilator. And you can see all that white cloudy stuff on both sides of that scan. That's all cancer filling up her lungs. And she was probably a week from dying in the ICU. And we discovered that her tumor had an ALK fusion positive rearrangement. And so this was just the year that crizotinib was first approved. And so we didn't know. So we said, all right, well, let's crush this up and stuff it down her feeding tube while on this ventilator. And I saw her in clinic 5 months later, and literally her CT scan report was one word: normal. So this is not subtle, and this is not by chance. This is because the science told us that there was this abnormality, and science developed specific targeted drugs to that abnormality. And this lady got off the ventilator within days, was out of the hospital, and went back to a normal quality of life. Ross talked about super survivors. This is what happens when you apply science to medicine in an intelligent way. And this is really, it has stuck in my mind. And when that advanced by itself too. So this is what happens. This is this waterfall plot where each bar represents a shrinkage of a patient's tumor. They're all below zero. This is what happens when you match a treatment to a marker like ALK, alectinib and ALK fusion. Virtually everyone responds. Some of them have dramatic and deep responses. And with the new drugs, you have responses in the brain as well. Brain metastases are a huge problem in lung cancer. And we're seeing that you can now medically treat brain metastases. And some of these patients may never need whole brain radiation. And I find myself, person presents with metastatic lung cancer, multiple brain metastases. I often have to snatch them away from radiation oncologists and tell them we need to do the genetics before you give them whole brain radiation. Because if we find an ALK fusion, these people are likely to live long enough to see the debility that whole brain radiation can cause. And it not only treats brain metastases, but these new drugs can prevent brain metastases. This is from a trial comparing alectinib to crizotinib. And on the right side, you can see the curves of patients developing brain metastases. And on the top is crizotinib, where half the patients develop brain metastases while on crizotinib, but only 9% on alectinib. So these are people who would have gotten brain metastases that were prevented by the modern drugs. And now we have some long-term data on some of these trials. And this is from the ALX trial, which shows that at 5 years, we have more than 65% of people alive on this study. And when you compare that to, say, the 30-month, 40-month time frame there, to the study I showed you before with chemotherapy at 40 months, virtually no one's alive. And with the ALK-treated patients, we have 75, 80% of people still alive at 40 months. And just very recently, there's been a new driver fusion that's been reported. It's in a gene called LTK. And I really had never heard of this until recently, but it turns out that it's highly related to ALK, and it also is activated by fusions. And it turns out that it's actually inhibited by ALK drugs. So you guys should probably also include LTK fusion patients in your group here. And it's interesting because now the science is advanced so that these people who identified this LTK fusion generated all of the possible resistance mutations and have tested them against all the advanced generation drugs. Before these patients even develop resistance, we now are at a point with the science where we can predict where resistance will happen, and we're ready for it. And I think this is fascinating. So all this is really a great improvement, and we can be very happy. We now have 5 years survival of 70–80% with alectinib. But this, you think about it for a minute, and 5 years survival, it doesn't sound that great to a 50-year-old. In fact, it really stinks. And we have to do a lot better than that. And so what's new? I mean, we've heard about a lot of great science being presented, but this is just the CROWN study, first-line lorlatinib, showing really good progression-free survival improvement over crizotinib. And intracranial time to progression is incredible in this disease, in this treatment. We don't have, very few of these patients had brain metastases, but I think it is an unfortunate truth that ALK tumors, if patients live long enough, will eventually become resistant to the current drugs. And the resistance has been shown to be, on target and off target. We've talked about this a lot, different mutations that arise in these patients' tumors that make them resistant to the drug. And all of these different single mutations have been profiled with the different drugs, and some of them are sensitive to some and some are sensitive to others. Of the single mutations, lorlatinib tends to hit most of those. But we now follow these patients often with ctDNA, circulating DNA in the blood, where we can follow the development of these mutations in different generations of drugs. And those little balloons that you see there are evolving tumors that become resistant to the different drugs and develop these different mutations until at the very far right there, usually there's a compound mutation that develops that we don't have currently approved drugs for. But there are new drugs that have been developed. This is pretty exciting, that specifically act against those compound mutations. And we're really enthusiastically awaiting the results of trials testing these right now. There's a phase 1 study of this TPX, and there's another drug called this NUV655, and it's billed as a TRAC-B sparing ALK TKI, and that is designed to avoid some of the CNS side effects and some of the side effects that we see with these drugs. So that's pretty exciting. And this drug also has specific activity against these compound mutations. And this is also in clinical trial. So how are we going to make progress beyond the development of new TKIs? We've talked about immune targeting things. I'm not really going to focus on that, but I think that's extremely promising. Cell-based therapies, we talked a little bit about TIL and TCR transduced T cells. That also looks promising. But I think really the next leap forward in this disease is not going to be trying to chase resistance after it occurs. It's not going to be trying to figure out what happens 8 years down the road when the tumor becomes resistant, but it's going to be treating these tumors up front and turning these responses into cures. So most of these patients have rapid shrinkage of their cancer, 70, 80, 100% of radiographic shrinkage of the cancer in the first month or two. But there's that little kernel of tumor cells that are present that are resistant to the drug, and they don't die. And they can sit there for years and years, and that tumor is trying to figure out ways it can grow in the presence of the drug, and they eventually do, and that's when resistance grows out. So if we could figure out how we could kill off that little kernel of residual tumor and we would improve at least the depth and duration of the response, or even talk about cures. when we first started treating lymphoma, and I'm a lymphoma survivor, the people tried Cytoxan. We got nice tumor shrinkages, but the tumor always came back. But then we used combination therapies right up front. It was more toxic, but with just a short period of therapy, we were able to kill off that last lymphoma cell. And I personally think that that's where the field should be heading, trying to figure out how to kill that last ALK positive tumor cell right up front and not chasing it down at the end. So I think we need to figure out how to co-target these residual tumor cells. And we heard a little bit from Dr. Awad and Charlie yesterday about how maybe combining a vaccine with the TKI or the YAP targeted therapy with a TKI, but up front and not at resistance, is a step in this direction. So we've actually been studying in my lab EGFR mutant tumors, and these are tumors like ALK mutant tumors. Same thing, beautiful responses, tumor always comes back. And we've shown that this resistance is due to induction, at least in part, by induction of beta-catenin, another signal pathway, like Dr. Babona's YAP. And this just shows, it's a little complicated figure, but this looks at a stem cell marker called ALDH in an EGFR mutant cell line. And you can see at baseline, that little boxed in area shows that about 1% of the tumor at baseline has this stem cell behavior. But just after 4 days of erlotinib, 42% of the tumor is now resistant to erlotinib and has that stem-like characteristic where it's resistant to treatment. And we can show that in that just that 4 days, dramatic induction of this beta-catenin signaling. So we've developed a clinical trial that's actually open now, where we're going to be treating from day one with the EGFR inhibitor. We are treating because it's open and we have patients on the study. We're treating from day one with the EGFR TKI osimertinib plus a beta-catenin inhibitor. And these patients, so far, tolerated this treatment beautifully. And knock on wood, not a single patient on this study has progressed yet. And so I think we need to start thinking about really trying to do the same thing with ALK. So let's talk a little bit about early stage disease. I know probably some of the people in this room had resectable tumors that eventually recurred and now are being treated for metastatic disease. And even when resectable, about half the time tumors recur. So what about ALK positive tumors that appear to be resectable? So there's an ongoing study that looks at alectinib in the adjuvant setting after surgery to see if it will improve outcomes. There's another study looking at ALK inhibitors in ALK mutant patient tumors before surgery. It's called neoadjuvant therapy. And I think these are all promising approaches. And this is a study that combines ALK targeted drugs with stage 3 cancers after chemoradiation, like what the Pacific trial is with immunotherapy. And I think all of these deserve exploration. And this is, I think EGFR kind of led the way here with a trial called ADORA, where they looked at the addition of osimertinib after surgery for EGFR mutant patients. And there's a dramatic improvement in disease-free survival in these patients. But there's 3 years treatment with osimertinib, and you can kind of see after they stop the 3 years treatment, the curve is notching down a little bit. And I'm a little bit concerned about that, especially when we're talking about now the overall survival really isn't much different. And after 3 years, the curves come together. So I'm not sure how this is going to play out. And there are now some data 6, 7, 8-year data combining first or second generation TKIs with after surgery. And you can see on the left there that there's some improvement in disease-free survival early on, but that the curves after you stop treatment come together at the tail there and at a very low level. So these are resectable patients with less than 20% progression-free at 5 years. And you can see a little bit of a bubble in the survival, but at 5 years, really absolutely no different, and a pretty poor survival in these patients. So I'm not sure that adding TKIs to surgery is going to be a big step forward, unless maybe we can find the combination to get rid of that little kernel of cells that's residual. So I think there's been a lot of exciting progress in the therapy of all stages of lung cancer. I think survival and quality of life are improving. 5-year survival should be our new benchmark for metastatic disease. And some people surviving 5 years of metastatic disease is great, but it's not good enough. We can't be happy with that. I really think we need to be curing this disease. And so there's a lot of work that needs to be done. And I think that it will come from better science, leading to better therapies. And we also need to pay increased attention to helping people live better as well as longer. And Jill Feldman in the EGFR space really talks about this, how even a low-grade toxicity over a long period of time, which you experience when you're taking these daily TKIs, really is not ideal. And so we need to not only talk about efficacy, but talk about quality of life. So I'm going to end with another patient story, and this is addressing clinical trials. And we talk about clinical trials as being human experimentation, and specifically phase 1 trials. The purpose of a phase 1 trial is determining the maximum tolerated dose before you kill people of a new drug. But I push back and I say nothing would even make it to a phase 1 unless we thought it would help people. So my goal in phase 1s is helping people. And with science-based therapies that are being tested today, this is often the case. We're often seeing real clinical benefit in phase 1 trials that we didn't see when we were scraping fungus off rocks and looking for cancer therapies 30 years ago. So I'm going to just show an example of a patient. This is a patient that doesn't have ALK positive disease, that has small cell lung cancer, which is a really terrible, fast-growing, aggressive lung cancer. She was treated with chemotherapy end of 19 to early 2020, maintenance immunotherapy till 21. Then she had progression, brain, lung, and adrenals, got radiated. And she had a repeat chemotherapy through November of 21. But after just 2 cycles, she had progression in her liver, lung, malignant pericardial, and pleural effusions. And so we put her on a phase 1 trial of this AMG 757 bispecific antibody. And she only received 1 cycle. Last dose was in early February of 22. And she was taken off study for technical reasons. But then her scans after that showed a complete response that's now been maintained for more than 6 months. And this is her scan on the left with big liver metastases, you can see. And then on the right, just a few weeks ago, absolutely gone. We would never see this with chemotherapy. And this is a phase 1 clinical trial. So the message here is clinical trials aren't for guinea pigs anymore. Clinical trials are what you should investigate. And even phase 1s can result in clinical benefit. So it's one of my last slides here. I want to talk a little bit about this painting. So this is a painting called Blue Beautiful Skies that's on the ground floor of our cancer center. And it was inspired by a patient of mine who was a young, never smoker, took care of herself, ran an art studio, and she had EGFR mutant lung cancer. We started her on targeted therapy. She had a beautiful response, and she texted her artist friend there, Paul Hamilton, that, you know, skies were looking really gray, but now all I see is blue, beautiful skies. And he was inspired to paint this painting for her, which I think is fantastic. It's a positive, beautiful image depicting progress in lung cancer on the ground floor of our billion-dollar cancer hospital. But it also tells it's missing pieces. There's pixels missing in this painting, which to me symbolizes that there's still progress to be made, that we need to keep working to fill in the missing pieces and turn these responses into cures. Unfortunately, this lady lived 7 years and recently died of her EGFR mutant tumor. And I wish we had had this trial open so that we could potentially have prolonged that treatment course. But to me, lung cancer is often invisible, and it doesn't get ground floor presence in cancer hospitals. But this is, I think, a positive message and a forward-looking message for lung cancer in our hospital, and it really depicts the way I feel and my team feels about moving forward. So I think we've made major progress, and all this translates into hope, but there's a lot of room for improvement. We need better drugs, better biomarkers, better science, new ideas and approaches. I think we need some radical thinking. We can't be happy with the responses we're getting with alectinib and lorlatinib. We can't say, well, we're doing so well, we can't try adding things at the beginning to try to cure this disease and not just shrink tumors. And I loved the statement yesterday, if it comes up. If you have to walk through hell, act like you own the place. Nobody asked for this disease, right? Nobody asked for this. And I heard it mentioned yesterday that people think that they view it as winning the lottery. This is not winning the lottery. This is a terrible diagnosis. And you didn't choose that path. But if you find yourself on that path, take charge and make a difference. And that's what you all are doing today. I'm very proud to be a little part of this and help in any way I can. Thank you very much. So I actually finished a few minutes early, and I'd be happy to take questions. Nope, no questions.
And in many of the community cancer centers, what do we need to do as patients and advocates to correct this gross error?
Yeah, it is actually a gross error, but you have to understand that these centers are under-resourced to get things, but it makes such a difference that it really needs to be mandated. And Dara Eisner hates it when I say this. Is she here? You would never see, huh? Well, I'm 67 years old. I say everything with impunity. I don't care. But you would never see a breast cancer report without ER, PR, HER2 status. I don't think pathologists should be paid for a lung cancer report without genetic biomarker testing. That should be part of it. And it should be a hospital quality metric, not just testing being done, but testing being done and influencing treatment decisions. And to me, that people send off these things and then they ignore them. How often, Ross probably has seen this all the time, get an ALK fusion patient who started on chemo pembro. And what do you do with that patient? What do you do with that patient? You keep them, if they're tolerating it, you keep them on it? Yeah, I think that's a good plan. But these people, oh, well, all the time we see people are just starting chemo, pembro, and everything. And if we've not learned anything from the driver mutant positive disease, it's matching treatments to patients makes all the difference. You can't just do a one-size-fits-all treatment. And with immunotherapy, unfortunately, we're regressing to a one-size-fits-all. Everybody gets chemo, pembro. And so the guys in the community, they have 30 patients to see that day. They just start chemo, pembro on everybody, and don't wait for the biomarker testing. And so when we see a patient in second opinion, my doctor just gave me one dose of this, while I was coming over to see you for a second opinion. And usually, like Ross replied, I would drop the pembro and keep going with chemo. If they're tolerating it and the tumor is shrinking, I would keep it going and then have plan B. So I agree with that. But, the answer to your question is complex, but I think financial incentives often work. Other questions? It's such a tragedy for these people. I have seen people that are they're getting like third line docetaxel and they're ALK fusion positive and they've never had alectinib. I mean, this is like super malpractice. Well, that's one way to teach people, to avoid bad behavior. I can't advocate for that, but.
I have a quick question. You keep talking about no chemo, but is that just for, like if you are diagnosed under stage 4, is going to chemo and radiation or surgery still the best option, even if you're out?
But don't misinterpret me here. At the current state of knowledge, if we use all of our ALK TKIs, there's no clinical trials available. Chemo is the best option, and ALK fusion positive tumors often respond well to chemo. And in early stage patients, we've also had patients with a resectable lung cancer who say, but this report says I have an ALK fusion, and maybe I should just take alectinib. No, right now the state of the art in early stage is to have surgery just like everyone else, because there is curative potential in surgery for ALK and not with alectinib at this point. So it's a complicated field, but I think there is a role for all the modalities. And Ross talked about using targeted radiation to residual sites of disease or oligoprogressive disease. The management of lung cancer has really become complicated, multimodality approaches, and we're still learning how to best combine all these things. Can we use ferroptosis to kill remnant cells? There's all kinds of different ways to kill cancer cells, and one of the ways cancer cells die is by ferroptosis. And I think that we really need to research different ways of killing those residual cells. Just like Trevor Bivona talked about yesterday, we need to study those cells. We need to biopsy those cells a few days after treatment, figure out why they're not dying, and then test different ways to kill them. Okay. I've got to run.
I'll be real quick. This one's a little bit off the clinical side, but we have a group of, patients and caregivers in the room. We've done amazing things. We've raised money for research, funding, advocacy, you name it, across the board, right? So my question is more around, with the exception of funding and money, because we know how underfunded ALK research is, what can we continue to do as a group to promote research moving more rapidly? And the second part of my question is, what's the biggest barrier that you see in terms of advancing research right now? And what can we do in this room to kind of help overcome some of those barriers for you guys?
Those are big questions. I think doing what you're doing is a great step. Awareness, get in front of news media, make it clear to politicians and lawmakers and resource allocators and hospital administrators that lung cancer shouldn't be invisible anymore. And that's what you're doing. You know, the Department of Defense gives $200 million a year to breast cancer, and I think 16 million to lung. I spent 15 years working in a VA hospital and 3 years at the Bethesda Naval Hospital. I don't think I saw a handful of breast cancer patients in that whole time in the military, but I've saw hundreds of lung cancer patients. And you know how that happened? Because people stood outside their Congress people's door and made it clear to them that there was a passionate and engaged community that wanted them to recognize lung cancer as not being invisible. And so I think doing what you're doing, but not just talking to each other, advocating for lung cancer in general, you're in the same boat as the EGFR mutant tumor patients and the KRAS and ROS and RET. So advocate for molecular testing in hospitals, advocate for it being a quality metric, advocate for financial incentives to do the right thing in lung cancer. And all those things that you're doing, I think, are all steps in the right direction. There's no magic solution, but I really think getting the best researchers into lung cancer research and keeping them there is going to pave the way. And unfortunately, for all of you with skin in the game, you know, there's an urgency to this, and we don't have all the time in the world to find these new treatments. I don't know if that answered your question, but I'm out of time. I've got to catch a flight.